welcome back to our continued discussion on when is it okay to stop our disease-modifying therapy. In August, when Dr. Thrower did this presentation, there were a number of unanswered questions at the end of the hour, so he has been gracious enough to come back and put in some more time in answering those questions. I see that we have one question in the Q&A right now. And so this person, Pam, says that she's 63 and in 2020 was incidentally found in MS was incidentally found in a brain MRI. She has about 25 lesions, no spinal lesions. A lumbar puncture confirmed that she has MS and she is 100% asymptomatic. Diagnosed with CIS or clinically isolated syndrome because she'd had vertigo for a week 20 years ago. So this is assumed to be the first and only symptom. She's gone 58 years having no idea that she has MS. So she never knew to take a DMT and started Tecfidera only taking the lower dose. Stopped it 5 months ago because she's tired of the awful GI side effects. 1. Should I try a different DMT? And if so, which are best for someone who has zero MS issues? And 2, is it unlikely my MS suddenly becomes active for some reason? So she's 63.
Great questions. The irony of her asking this question is just before this webinar, I had a gentleman, 79-year-old gentleman with almost the identical story. MS picked up incidentally on an MRI. So with the new 2024 McDonald criteria, when we think about radiographic isolated syndrome, so if you have an MRI that looks like MS, but you've never had symptoms, we call that a radiographic isolated syndrome. With the new criteria, if you do have oligoclonal bands in your CSF, you technically do meet the criteria for an MS diagnosis. I think that gets very academic, what label we use, because I think at the end of the day, the thought process should be the same. And that is, you've got an individual who's probably had white matter lesions on brain MRI for many, many, many years and has been asymptomatic. So is it likely that this is going to take off and do something different? While we don't have a perfect crystal ball, for most people, it would be unusual in an older individual based upon what the human immune system does. So I think it's unlikely that this is suddenly going to take a sudden turn downwards. Should you be on a disease-modifying therapy? I think if there was ever a case for shared medical decision making between you and your team, this is it. There is no absolute right answer, and so a lot of this is going to come down to your risk tolerance. How much of a hassle is the medication? Like the gentleman I saw earlier today was also on dimethyl fumarate, a generic for Tecfidera, and he very much wanted to be off of it. I think it is, in my opinion, I think it is okay to watch individuals like yourself. We do have tools now that we might use that can aid us in maybe making sure that nothing is going on under the surface. We have blood test panels, whether you pick just an isolated blood test like neurofilament light chain, or you do a broader panel like the Octave biomarkers, which looks at 18 different biomarkers. I think those can be useful adjunctive tools to let us know where your MS is at. If you have the ability to do more sensitive MRIs, some of the quantitative volumetric MRIs, and there are tons of these programs. The Octave group, for instance, has an MRI panel that looks at for some of these more subtle changes. Here at Shepherd, we use one called IQMS. So if your MRI were to change in this situation, it might not be new lesions on MRI, it might be more subtle changes. So when we look at some of these more subtle findings in older individuals, it might be things like slowly enlarging lesions or paramagnetic rim lesions. These are not always very obvious on standard MRI, but we're getting better at looking for them. So I would say these quantitative MRI programs like the Octave program, the IQMS, are really good at looking for slowly enlarging lesions. So that's a lot to take. I think this is a great example of shared medical decision making. and the person living with this situation is going to have a large say in what direction you go, whether you go back on a treatment or don't go back on a treatment.
Her second question is, did you have, I mean, it was actually her first question. Do you have a suggestion for a different DMT with the Tecfidera causing
Yeah,
such GI issues?
so I think that a lot of people where maybe we don't want the biggest gun that we have in our arsenal to in this situation. I think a medication like teriflunomide, the generic for Aubagio, can be a nice fit for individuals like this, where you want to be on a something that's easy. It's a once a day oral medication with a relatively low side effect risk, but still offers at least modest protection. Um, I don't know in this particular situation if I would go to one of the B cell depleting agents or a natalizumab. We certainly like those high efficacy drugs in younger individuals with MS, but we also know that especially with the B cell depleting agents, that as we age, that the risk goes up with those drugs, especially in women with MS. There seems to be a point where the risk outweighs the benefit, mainly due to a higher risk of infections.
Thank you. Karen is 62 and was just diagnosed in March of this year. She did have enhancing lesions and wants to know how long she should stay on a DMT.
Yes. So there are these folks whose immune systems just didn't read the rule books. I mean, you wouldn't think that someone with 62 would still have enhancing lesions, but that's what keeps us humble in the MS world is people who just their MS behaves a little bit differently. I don't know that there is a time limit. So we know we would like to get your MS under control. The goal with someone who comes in with enhancing lesions, well, like a lot of people with MS, is going to be no relapse, no new lesions on MRI, no progression of symptoms. This would be a great case where we might use those biomarkers we were talking about, the octave, get that blood test. And you would expect it might show some of the markers for neuroinflammation. Put the person on disease modifying therapy, showed that those biomarkers, the MS disease activity score gets better. And then I think the how long is certainly open for discussion. This is a little outside of the norm. A lot of times we're at age 62, we're starting to talk about coming off of treatment, or she's just starting her MS journey. Again, I think it's going to be it's kind of a risk benefit discussion. I would probably go at least till age 65 and make sure things have really stayed quiet. A lot of the studies where we're looking at discontinuation, we want to see people free of MRI activity per the DISCO MS study for 3 years, and they were free of relapses for 5 years, so that we'd have some comparative data to look at. I think one of the themes folks are going to hear through a lot of this is, we have some data to look at, the 3 studies that have looked at stopping treatment, but it's unlikely that we're going to have a study that's going to fit each individual situation. So in some ways, this is going to be really a lot of discussion between the person living with MS and their healthcare team about what we know and don't know and what your risk tolerance is.
This individual is posting anonymously. She knows that, or he, I'm not sure who, which, but they know the show is about stopping the therapy. Their question is it too late to begin MS therapy? They're 73. They've got lots of spasticity and leg weakness, which has gotten worse in the last 2 years. Should they stay away from a DMT and just treat the symptoms?
So I think, when older individuals, have things that are progressing, it kind of fits into that PIRA, progression independent of relapse activity, sort of category. And we have to think about what drives someone like that. Why is the spasticity worsening? Why are maybe some of the other symptoms like gait worsening? Is it true big inflammation? And frequently it's not in individuals like this. We do an MRI, we don't see new lesions. Maybe we do, some of the biomarker tests and we don't see big inflammation. So this then leads to that discussion of kind of very low level smoldering inflammation. Could that be driving what this person's dealing with? Or is it not inflammation at all? Is it loss of compensatory mechanisms, loss of neural reserve? Um, I would say my excitement for starting a DMT in someone in that situation is pretty low. I would much rather focus on aggressive symptom management, going after the spasticity aggressively. I think with the scientific advancements we've seen over the years with disease modifying therapies, one of the prices that we've paid is sometimes I think we spend so much time focusing on that we forget the basics that, managing spasticity, using our team, our physical therapists and occupational therapists, managing bladder symptoms. And I think in terms of improving quality of life, sometimes we get a lot more bang for the buck doing that than we would starting a DMT in someone like this. We have tolobrutinib on the horizon, maybe that date, the FDA potential approval date's been pushed back to December. Would that be a fit for someone, like this that is having some slow progression? They might fit with a secondary progressive MS without activity sort of categorization. Maybe. I think, if it does get approval, we're certainly going to want to look at the safety issues that could go along with that drug.
Thank you. Margaret is 67 and has been on Copaxone for 25 years and wants to know if she can stop taking that anytime soon. She does walk with a cane. She's not walking far and uses a wheelchair when needed.
I'm sorry, I missed the age.
She's 67.
So she would be someone that might fit, with that DISCO MS study, the discontinuation MS trial, where they looked at individuals, above age 55 who were generally stable. And they were on typically either glatiramer, Copaxone, or one of the interferons. And in that study, when they discontinued the drug, there was a low risk of disease progression. There was a little higher risk of more MRI activity in the group that stopped treatment, but that didn't seem to translate into more disability progression. So she would be exactly the kind of person that I would have a discussion about stopping therapy in.
Thank you. An anonymous attendee is 65 and is now eligible for the high dose flu shot. Should they get the high dose flu shot or the regular dose, and how will the high dose flu shot affect their MS?
So there's tons of data out there looking at the safety of influenza vaccines in people with multiple sclerosis. Um, I assume this person is either not on a disease modifying therapy or not on one of the B cell therapies. Certainly the B cell therapies kind of, affect the efficacy of our vaccines, but assuming they're not on a B cell depleting agent, I I think everyone, really needs to give strong thought about getting influenza vaccine. Flu still kills people every year, and our ability to fight off influenza diminishes as we get older. So I think the higher efficacy flu vaccine would be perfectly appropriate for this person.
I can tell you that I've had the high dose flu vaccine for the last several years now, and it has not impacted my MS at all.
Yeah.
So I personally will say that have not experienced that. I think it's safe. I've got a 45-year-old anonymous attendee who just finished year one of Mavenclad on August 8th. They're hoping to start year two in June of next year. What are the chances that next year may be the last time that they ever need to do any treatment for their MS? They've heard that there's 15-year data on the
Yeah.
efficacy of Mavenclad.
I think that is exactly the hope in someone like this individual. So at age 45, we get the second round of Mavenclad in. Like you mentioned, you've got 15-year data showing that the majority of people are, have stability 15 years out. So that puts this person now up to age 60, where we're starting to have that discontinuation study. So I think it's a very realistic possibility that this is the last DMT that they see, hopefully.
Thank you. Linda got a stable MRI result today, and the neurologist is suggesting she go off of her DMT, which is Avonex. Last year, he offered Rituxan. She's been in PT for a year to gain strength and endurance. Could you please explain how the Avonex is no longer working? Isn't it still protecting me? I've been on it since 1999. How do I know if I have Pira or just smoldering going on? I am 64.
Yeah. So it's interesting. They kind of talked about two very different pathways, stopping, sound like stopping DMT, Avonex versus switching to Rituxan, which, I think those are very different pathways. So PIRA, the progression independent of relapse activity, I would put smoldering inflammation under that category. So what causes PIRA? Smoldering inflammation is one potential mechanism that we see PIRA. There are others like loss of neural reserve, deconditioning. So in an individual with PIRA, how do we know if it's smoldering inflammation? I think we can use those biomarkers that we mentioned earlier to see if there are any markers for low-level inflammation. They're probably better at picking up big inflammation than low inflammation, but I think it is a useful piece of information. So what are the MRI markers for smoldering inflammation? Well, it's probably the slowly enlarging lesions that if you're getting some sort of quantitative MRI, we can potentially see that, or it's the type of MS lesion called paramagnetic and REM lesions. And the radiologists now are getting pretty good about incorporating that into our MRI protocol. So those would be the two markers we would look for on MRI to suggest that there's smoldering inflammation. If you have it, if there are one of those MRI markers and there's some suspicion that there's smoldering inflammation, then the next question is, do we look at tolobrutinib once that drug, if that drug gets FDA approval? So a lot of moving parts in these decisions that have to be kind of factored in.
Thank you. Evelyn is 78 and has been on Vumerity for the last 2 years. The last few days, she's had terrible flushing a few hours after taking it, isn't sure what to do. She also takes delphampridine and has been on that for 20 years.
So it's interesting with the fumarates, whether it's dimethylfumaric acid, or Tecfidera, the Bifirtam or Vumerity. We see individuals who've been on these drugs for a long time, and then all of a sudden flushing pops up again as an issue. Remember that these drugs are very food sensitive. The more food you have on board, the better. You tend to lessen the likelihood of the flushing. If you're still getting flushing in spite of having a good amount of food on board before you take the drug, talk to your healthcare team. There are some other tricks out there, some oral medications that we might add with a drug like Vumerity to minimize the flushing. And then I think the other discussion is, at her age, is there a possibility she could come off of it altogether if this is an ongoing issue?
Thank you. An anonymous attendee writes that they were on Mavenclad for 2 years. They're not on anything at the moment. The doctor says the meds are still in their body. They notice that walking has gotten worse. Should they be concerned or should they be on something else? And I know you've addressed that with a couple of our attendees.
Yeah.
So
And so really realize too with Mavenclad, the drug itself is not still in your body. So it's the immune effect that lasts for such a long time. So what Mavenclad is really doing is kind of reprogramming your immune system. It's going to knock down both those B and T cell subsets. And when they come back, the hope is that they come back in a sort of a less inflammatory state, and that less inflammatory state lasts for years and years and years, whereas the drug itself is long out of your body. So this person is kind of describing PIRA, and so again, I would have that discussion with your team and talk about what do we think is driving this? Is this something that really is more appropriately addressed with very aggressive rehabilitation and symptom management versus another disease modifying therapy?
okay. I have an anonymous attendee who is 62. They've been on 3 different DMTs over the past year, all giving them allergic reactions. They had flare-ups approximately 3 months ago with 3 days of IV Solumedrol. Do you think the body is telling them that it's time to stop DMT attempts?
Yeah, I don't know that I would use, reactions to, side effects of the drugs as an indication that you shouldn't be on anything. You may just be one of these unfortunate folks that just, we see people that just seem to have side effects to everything. If there's a, 1% chance of this side effect, they always seem to be in that 1% group. And so there's, unfortunately, sometimes is just a lot of trial and error. If your MS team really thinks you need to be on a DMT based upon MS disease activity, I think it's probably more likely that we just need to keep looking for something that your body's going to be happy with.
Thank you. Pam wants to know what kind of side effects your patients are having on Aubagio.
So, with the Baggio, when you first start it, we do sometimes see some transient GI side effects. Most people get through those, and then the side effects are, tend to be pretty minimal. We see hair thinning in some people. I've had people find it bothersome enough that they go off of the drug. We do want to do liver function studies and blood counts, especially early on in treatment. And then I think the sneakiest side effects is peripheral neuropathy. And the way neuropathy typically manifests is, sensory changes in the feet. And the reason that's so sneaky for people with MS is there's a tendency for them just to say, oh, it's my MS that's acting up. So anytime you have new sensory symptoms on Aubagio or the generic teriflunomide, let your healthcare team know that. If there's a suspicion that it's neuropathy and not MS, they're going to refer you for nerve conduction studies. That is a deal breaker. If you have evidence of peripheral neuropathy, we need to get you off of the drug if that's the case. But most of my folks tolerate Aubagio teriflunomide really well.
Thank you. Michael is 70 and started Ocrevus in 2017 with no side effects. Neuro took him off due to age. His balance is worse. Should he go back on?
So then I think in this situation, the question is, are things worsening because you're not on a DMT, or would they be worsening on the DMT? Because we certainly see a lot of older individuals who are still on DMTs who see some subtle progression. And that may be either because of PIRA, that there's some low level inflammation or loss of neural reserve. Um, my excitement about having people on a B cell therapy, into the 70s gets a little bit less just because of the risk for infections. So I would talk to your team and talk about that risk benefit ratio, talk about why they think your gait is worsening. What are the non-drug options that we have for improving your gait? I keep coming back to our physical therapy friends. We do especially in this age group where walking becomes sometimes a little bit more of an issue. I mean, we really need to take advantage of the physical therapists. They have so many things in their toolbox that we can potentially help with. We like making sure people are engaged in a wellness program. Physical therapy never lasts forever. Our insurance companies are only going to cover so much each year, and we want to make sure you maintain those benefits, whether it's to a home exercise program or being engaged in some sort of MS specific wellness program if you have access to that.
Thank you. Paul is 65 and was initially on Tecfidera. He was diagnosed at 54. Switched to Ocrevus 6 years ago. His neuro just retired. He'll be meeting with a new neuro the middle of next month, and he's just kind of gathering information for the initial discussion. His symptoms are progressing a bit, but he's trying to battle it with nutrition and activity. Doesn't Don't know what his perspectives will be, but I do want to have a deep discussion. Should I ask him to use a biomarker test such as Octave?
I think so. So, when you're making this decision about staying on versus going off of treatment or de-escalating or switching to something else, I think you want to take advantage of everything you've got available to you to make as of an informed decision as possible. And I think the Octave biomarkers are just, a great piece of information to factor into that. But you need to take those biomarker results in the context of the big picture. How am I doing physically, and all of those things. I don't think we want to use the biomarkers in isolation to make a decision.
Paul has a follow-up question asking your perspective on the BTK inhibitors. Now, again, he started out on Tecfidera, and then for 6 years he's been on
Yeah.
Ocrevus.
Yeah.
So,
So I think the BTK inhibitors, tolobrutinib specifically, they do bring something new to the table. It's a different mechanism of action. It's kind of exciting in that they work on B cells through a different pathway. They probably, work on sort of that inflammation that's in the central nervous system itself that even our really effective current B cell therapies like Ocrevus probably don't address that, that the compartmentalized inflammation in the central nervous system itself. So they're exciting from that standpoint. I think, if you had someone with secondary progressive MS without activity who was progressing and they're not on a DMT and tolobrutinib gets approval, I think that's a pretty easy decision, assuming the safety looks good. If they're on Ocrevus and they're getting a little bit worse, and now you have tolebrutinib, I think that's a harder decision. Do you switch? You can't use them together. They do have very different mechanisms of action. Do you switch them over to it? Yeah, that's a hard decision, and I think we're going to learn a lot, assuming the drug gets FDA approval, about what that switch looks like, because you're going from a drug that in Ocrevus that covers one type of inflammation really well to a drug that covers a different type of inflammation, and you just don't know in a given individual which inflammatory pathways are driving their MS. We would assume in an individual in their 70s that if there is inflammation, it's going to be more that low level smoldering inflammation. So maybe that's a good argument for switching to something like tolebrutinib. And what we would love to see is a study looking at putting those drugs together, but I think that's probably years down the line until we get that information.
Thanks. Machika is 61 and has been on Briumvi since June of 2023, has been losing a lot of hair since then and wondered if this could be a side effect of the medication.
So there's these certain side effects that we see that, are listed as very unusual with given disease modifying therapies. I think hair loss is one of those. I think I have seen hair loss with every MS disease modifying therapy out there in some individuals. I think they all have the potential to do it. And this is where it comes down to, if the person says, I started drug X and now I have hair loss, and that is the only variable that changed, and the dermatologist says there's no other explanation, I think we have to assume it's probably drug X that's doing it. And then it becomes kind of a quality of life question. Is it tolerable to you? Is it something you're willing to put up with? Or has this become a deal breaker and we need to move to something else?
Thank you. Pam lives in California and wants to know if she can arrange a second opinion with you. If so, does it have to be in person or can it be on Zoom? She's 63, diagnosed with clinically isolated syndrome and has no symptoms. She's trying to decide whether or not to go on another DMT.
So we are more than happy. I know most MS centers around the country are more than happy to do second opinions like that. Unfortunately, our ability to do telehealth across state lines has been seriously limited. Insurance companies are not typically covering telehealth across state lines now, which is silly because that's the exact person that you want telehealth for. So yeah, I would say from an insurance standpoint, it has become almost impossible. We do have people who do telehealth across state lines and just do self-pay. I hate for people to have to do that, but certainly you can reach out to our Shepherd folks and we could talk about different options to see if we can make a remote visit work to save you a long journey from California to Georgia.
Thank you. I have a 56-year-old African-American female who was diagnosed with relapsing MS in February of this year. No lesions on the brain, is on fingolimod right now to slow down the process of the MS. When would they be allowed to get infusions? They hear that it helps with energy levels.
So I'm not sure which infusions we'd be talking about. I mean, if you're looking at FDA approved disease modifying therapies that are given by infusion, you're really looking at either one of the B cell therapies or natalizumab. And so that's a discussion about, do you switch over to one of those? I wouldn't, it always worries me when we hear someone say, I want to go on a disease modifying therapy to help with something. We really, even with our highly effective disease modifying therapies, when we head into those, we really think of those as more of an insurance policy of the future. It's going to stop things more than make things better. Do we see lucky individuals who who feel like they get an energy bump from our infusible medicines? We do, but I think we never want to make someone think that that's what the drug is designed to do. They're really designed to keep you the same. I'm not sure if she's referring to maybe some of the alternative therapies. We have people that do things like glutathione infusions for energy, and that's I think that's a case of buyer beware. There's not a lot of hard data to show that those things are good for energy levels. If energy is an issue, I mean, talk to your healthcare team. There are certainly other options for lassitude or fatigue in MS. We know that's a huge issue. A lot of people with MS list that as far and away their most bothersome symptom, and we can certainly talk about treatment options for that.
And sometimes even just checking B12 levels
Yeah,
and making sure that they're not deficient
that's
and need supplementation could
a
help
great
with that.
point. Yeah, we never want to miss the basics.
Yeah. Anthony is 62 and is on alternate dosing of Gilenya, alternate day dosing of Gilenya for the last several years. He wants to know if there's a special risk of worsening symptoms if or when someone discontinues Gilenya, the risk that is unlike the risk of discontinuance associated with other types of DMTs.
Yeah, so there was a study that looked at this, it was the DOT MS, and so they looked at individuals. Was it DOT MS or you? I'm sorry, it was the European study that looked at this. So and this was huge. I mean, thousands of individuals whose medical records were reviewed, and they looked at B cell therapies, fingolimod, and then natalizumab. There was some risk of relapse when people discontinued fingolimod or the natalizumab. So it wasn't high, but it was definitely higher than those individuals who were stopping B cell therapies. So again, talk to your healthcare team if you are thinking about going off therapy. I don't think being on fingolimod it makes it impossible for you to get off at some point, but just know there is a little bit higher risk, and maybe that's a person we're going to watch a little bit more closely as they stop that therapy.
Thank you. Anne is 72 and has been on Avonex for 25 years. She wants to know what people go through when they stop their DMT.
Hopefully nothing. I mean, especially with, we've got good data for the interferons like Avonex, showing that especially in her age range, most people didn't, have progression of disability. Most didn't have relapses or new lesions on MRI. There's no withdrawal from our disease modifying therapies, and it's not also not like you have to taper the Avonex. When you take a dose of Avonex, the molecule or any interferon, the molecule itself is probably only staying in your body for 48 hours or so. Again, it's that immune effect that lingers a little bit longer. So, my folks that have stopped things like Avonex, they typically they have not seen any symptoms.
Thank you. Linda is 71 and has had MS for 30 years. Since April, have suffered with adverse reaction, probably Stevens-Johnson syndrome from Adderall. Decided to stop Ocrevus until skin lesions heal. Thoughts? Also developed POTS a few years ago. Have you seen this related to MS?
With a lot going on there.
Yeah.
So Stevens Johnson, we have to take that really seriously. I mean, that is a severe skin reaction, allergic skin reaction. It can be pretty serious. Um, it so I don't think the Ocrevus played a role. It sounds like it was the Adderall, and this is purely theoretical. Could the Ocrevus have actually been helping put a lid on it a little bit, or maybe even quiet it due to its immune modulating effects? Maybe. And then when you get your dose of Ocrevus, you do get a little steroid with it. So I think that it'll be interesting to see what the Stevens Johnson does, off of the Ocrevus. Luckily for most people, Stevens-Johnson syndrome is time limited. It's going to resolve over time, and as long as you don't reoffend with whatever that medicine was, hopefully you're not going to be at risk for it in the future. Was there a second part to that question? Yeah.
No, I think it was just they had POTS as
Oh,
well,
the
and could
POTS.
that be MS related?
Yeah, so that people with MS can get autonomic dysfunction. Um, I am not aware of a study. You may know, Sherry, that if there's any study that's looked at the incidence of POTS in MS. I don't think that I've ever seen anything that shows there's an increased incidence
I
over
haven't
time.
seen anything that says that there's an increase. And I
Yeah.
think, yes, we have people with MS that have POTS. For those that don't know what POTS is, it's a postural orthostatic hypotension. So people will stand up and pass out. And that happens in people that don't have MS. It happens in
Yep.
people that have MS because they're people. So I don't think it's MS related particularly.
And I think too, even if there was some, if in the future, if there was some study that showed that maybe there was some epidemiologic linkage, I don't think it changes the management of the POTS. I think you're still going to need to be working with, usually those are cardiologists, sometimes neurologists who are kind of experts in managing the autonomic dysfunction with POTS.
I have an anonymous attendee who's 59. They were diagnosed 2 years ago, but they had optic neuritis 12 years ago and other symptoms off and on since then. MRI only has 4 lesions. They've been stable for 2 years, on meds for 2.5 years with side effects to nearly all meds so far. On Rinvoq for rheumatoid arthritis, but also on teriflunomide for MS, but low dose every other day because it causes so much diarrhea. Is the teriflunomide even making a difference at this low a dose? And when can they come off meds for MS? Always have fatigue, cog fog, leg weakness, spasms, as well as poor balance.
So, I mean, you're certainly in the age range where you kind of fit with some of the studies that have been done looking at, at discontinuation. So, you know, we it's hard to know what's the basement effective dose with certain medications, and there's probably a lot of individual variability. Um, it's probable that you're not seeing a ton of protective effect at that low of a dose of teriflunomide, but we can't say it's zero. I think this is a person where it's certainly reasonable to look at, could you come off of a medication? I think the other discussion we have in individuals like this who have a dual autoimmune diagnosis, rheumatoid arthritis and MS, is if there is a thought that maybe you need to be on something for MS, could we find something that would cover both? So rituximab certainly kind of is something that fits that distinction. I don't know if that's ever been looked at for their rheumatoid arthritis. One of the jokes in the rheumatology world is when in doubt in rheumatology, throw Rituxan at it because it treats most autoimmune conditions. So that could be a thought also if it really is determined that you need to be on something for MS, maybe see if you can get one drug for both conditions.
Linda has posted a follow-up to her question about the Avonex. Could it still be working after all these years on it? The MRI showed stable, so not looking at Rituxan anymore. It was
Got it.
last year she was recommended Rituxan.
So we don't think that Avonex ever loses its effectiveness. It's not that you get tolerant to it or it goes away. So the drug is always the same. The bigger question, so it's not, are we questioning has the drug changed? The question is, have you changed? Has your immune system gotten to a point where you really don't need, to be on any disease modifying therapy, Avonex or anything else? So I think that's really the $1 million question, and that's kind of what we're talking about for everybody here. Is there a point where, based upon immunosenescence, have you just really outlived the usefulness of your disease modifying therapy, and we can safely stop it?
Pam wants to know if Mavenclad is likely to cause cancer in people over the age of 60. Do you recommend this DMT for older people?
So even though there's some language in the product information from Mavenclad about cancer risk, in the real world, I mean, this drug has had very heavy usage in Europe, probably more so than here in the U.S. But we've certainly used a lot of it here in the U.S. We just really have not seen that much of a cancer signal. To my knowledge, I don't think Mavenclad carries that warning in the European with the regulatory agencies like we do here in the US with the FDA. So we want to do the cancer screening in all individuals before they start Mavenclad. Just if you're due for a colonoscopy, do skin screens, mammograms for women. But we just in the real world, the monitoring that's been done has just not shown much of a cancer signal. And I will give credit to the science folks at Sirona. They've done a really good job of keeping all of us up to date with any safety issues that might arise with Mavenclad.
They have. Summer's asking a question about the BTK inhibitors. If they do help with progression, would it be likely that they will be or prescribed for people with primary progressive MS? And I think that we've got a couple of studies going on right now with
Correct.
primary progressive.
Yeah, I mean the hope is, there's this thought now that when you think about the underlying pathophysiology of secondary progressive MS without activity and primary progressive MS, maybe they're really not that different. Maybe the underlying mechanisms are fairly similar. And so if something works for secondary progressive MS, like the tolobrutinib has been shown to do, there's great hope that it'll work in primary progressive. But like you were saying, Sherry, we don't have that answer yet. When and if the drug gets FDA approval, I think our hands are going to be tied. I think we're going to really need to stick to that secondary progressive MS label, or the insurance companies are probably not going to be happy with us. But hopefully, we'll get that data on primary progressive very quickly.
Thank you. Mary Beth from Facebook asks, she's 64. The doctor is talking about switching her from Kesimpta that she's been on for 4 years to Ocrevus because her walking difficulties are getting worse. What are your feelings about that?
Um, I in my mind, and I don't want to, dispute other healthcare providers, but I don't see a big difference between those two drugs. They're both anti-CD20 monoclonal antibodies. The mechanism of action is really almost identical, between Kesimpta and Ocrevus. When we make Kesimpta Ocrevus switches, we're usually doing it for reasons of convenience or lifestyle, or sometimes with Ocrevus, if someone says they have a wearing off effect, we might move to Kesimpta just because you have the every 28-day dosing. But I really don't see any good evidence to say there's a significant difference in efficacy between those two drugs. So I don't, I'm not sure that makes much sense to me.
Yeah, I haven't seen anything stating that one is superior to the other.
Mm-mm, mm-mm.
An anonymous attendee wants to know what is the risk of not taking a disease modifying therapy? They're 63. Now, there's no indication that they've been on one in the
Yeah.
past or so.
I mean, our goal for people, whether you're on or off treatment, is that your MS is boring and stable and not doing anything. So the risk in someone who's not on treatment is, could your MS progress? And at age 63, if it progresses, it's more likely to be progression of disability or these subtle MRI changes that we talked about earlier. But again, we've got all this data out there suggesting that, maybe at age 63 we don't need to be on something. So I think individually you just need to make sure you're staying in touch with your MS team. Don't fall off the radar. Make sure you're getting MRIs periodically, getting neurological exams, and telling your healthcare team if you are seeing some progression of symptoms so that you can talk about the plan.
An anonymous attendee had a severe DIV with rituximab. Does that mean all B cell meds are bad choices for them?
Um, I mean, there is a subtle difference in the way B cell therapies kill B cells, and this is something we're learning. So one of these B cell therapies kills your B cells, they can do it through complement mediated pathways or through antibody mediated pathways. And as they're engineering these monoclonal antibodies now, and it's not just in MS, you're seeing this in cancer management. They're doing something called glycoengineering. They're taking the sugar sort of moieties off of the business end of these monoclonal antibodies. And what that does is it drives the way we kill B cells more towards this antibody mediated pathway, which in general is associated with a lower risk of infusion reactions. So if you look at a drug like Briumvi, it is more driven through those antibody mediated pathways. So in theory, it should be associated with a lower risk of infusion reactions. Part of the reason why we can do a Briumvi infusion in 1 hour versus slower, rates with some of our other B cell therapies. So long way of saying maybe this is a person that tolerates Briumvi better than rituximab, but I would certainly have a lot of nurses on standby and I would not do a home infusion because you could still have an infusion reaction with Briumvi, even though in theory the risk is lower.
An anonymous attendee says, my mom is 65 and has been on Kesimpta since 2022. Due to her age, should she plan on stopping treatment or continuing? Her last MRI was in August of 24 and lesions were stable at that time and she's due for a new MRI now.
Yeah, I think this is certainly the person that we're talking about, right in that age range. Seems like things are stable. So again, I don't think we can say enough that, this really is a shared medical decision. We want so that we want that person with MS to know everything we know about all the studies that are out there, and be honest and say what we don't know. Maybe do the biomarkers so that they have as much information, and then let them make a decision. I have 80-plus-year-olds who are still on their disease modifying therapy because they are acutely uncomfortable stopping it. I think if they're on a platform therapy like a Copaxone or an interferon where there's very little risk, I'm fine with that. I'm not going to beat that person up and tell them they have to stop their treatment. A little different discussion if you're on a B cell therapy where you have some risk of infections. NARCOMS, the North American Research Committee on MS, did a study and asked people with MS, how comfortable would you be stopping your disease modifying therapy? And I think the number was 37% said that they would be very uncomfortable stopping their disease modifying therapy. I think that speaks some to just personality. If you're a person who doesn't like to rock the boat, I don't want to, let's say I have an 80-year-old who's on Copaxone and they really don't want to stop their therapy. I don't want to take that away and have them lose sleep at night and be anxious, worrying about things. Sometimes you pick the path that's going to do the least harm to the individual.
Thank you. Just a note here, we've got about 15 minutes left and we have 15 questions
All
in the
right,
Q&A.
yeah, move it up.
All
Yeah.
right, so Carrie is 71, has been on Ocrevus for 5 years and other DMTs before that. She gets very sick if she catches COVID. Doctor suggested Mavenclad to get her off of the Ocrevus. I'm thinking of stopping all DMTs. MRI shows no new lesions since starting on Ocrevus. Your thoughts on stopping?
That would be someone that I would be pretty comfortable having that stopping decision. So the question is, do you stop or do an exit strategy like Mavenclad? Either is a reasonable option. I'm a little bit more biased towards probably just stopping.
All right. An anonymous attendee is 62, diagnosed in 2022 with relapsing MS, started Tecfidera, now on Ocrevus since December of 23. I actually believe that I have secondary progressive MS since my symptoms seem to be worsening. Can the Octave test help with deciphering whether I actually have secondary progressive? And if I do have secondary progressive, should I discuss another treatment option with my neurologist?
Think determining relapse and remitting versus secondary progressive in people on treatment is very difficult sometimes because we're not seeing the natural history of your MS. Could we be stopping the big inflammatory process, but not everything and leading to some progression? I don't think Octave is that sort of test. I don't think it's going to help us say, you have one form of MS or the other. It's going to tell you whether there is, neuroinflammation. It's going to tell you whether there are cells being damaged. Um, yeah, that's a tough one in terms of, but I think I would go back to, our goal is to not have any progression. So if you're seeing progression, talk to your MS team and say, okay, what do we do about this? Or do we switch? Do we, do focus on rehabilitation and just come up with a plan?
An anonymous attendee says, my doctor wants me to start Zeposia, but says UTIs are a risk. A UTI was the cause of my last relapse. Have you had patients on Zeposia get UTIs? I'm female and 62.
So because of the way the S1P receptor drugs like Zeposia work, I mean, there is some risk of infection. I have not seen that to be a high risk in general. I think we want to look at UTI prevention for everyone with MS. So if you're at risk for for UTIs, I would step back and say, okay, well, even putting the Zeposia aside, what do we need to do to prevent those UTIs and talk about strategies for that? I don't know that I would let that be a deal breaker necessarily for starting Zeposia.
Ruby is 24 and has been on Ocrevus since diagnosis in 2023. Uh, she's lost the ability of moving on her own independently. The last MRI showed no new lesions. Any recommendations as to whether she should stay on Ocrevus?
So this is sort of that definition of PIRA, the progression independent of relapse activity. Um, Again, I think we've kind of covered this. It's kind of that risk benefit ratio. What would she look like without it? Again, this is a person I would want to be really aggressive with rehabilitation, independent from that disease modifying therapy, option. It seems like we're harping on that a little bit, but man, I don't think we can get that message out enough that you take advantage of your therapy teams,
Yeah,
through whatever that looks like.
exactly. Lori says, what do you think about vagal nerve implants for MS?
So vagal nerve stimulators are FDA approved for refractory epilepsy. There is some question as to whether they do more, that they're actually promoting remyelination. There is evidence in the animal model that they do remyelinate. So there is probably a trial coming up in the foreseeable future looking at vagal nerve stimulators as a neural repair mechanism. I don't know the timing on that. So I think it's an interesting line of research.
Next anonymous attendee is 71, diagnosed 12 years ago, although they're convinced they've had MS for many years before that. Over the past year, they've been on Rituxan for 10 years. Over the past year, they frequently get fevers around 100.8 at night. Primary care doc has no idea what's causing the fevers since blood work always comes back fine. Could this be a reaction from the Rituxan?
Probably not. I mean, given the length of time they've been on the medicine, I think it's unlikely that it's a Rituxan issue. Um, I would probably want to get that person in with infectious disease just to make sure there's not some underlying low level, occult infection that we're dealing with. But I think it's can't say for sure it's not the Rituxan, but I think it's unlikely that the Rituxan's doing that.
Thank you. James says he's late joining the discussion, but if this has been asked already, but I don't think it has specifically, when extending time frame between infusions, specifically Tysabri, is pushed out to 6 or 8 week intervals, how is the crap gap or slump week affected?
So that's going to be very individual. Not everyone gets that crap gap. So if I have a patient on 4 week dosing and they definitely get the crap gap, I'm probably not going to be very excited about pushing them out to 6 or 8 weeks for fear I'm going to really make them feel crappy for a period of time. Um, we use a lot of extended interval dosing, but sometimes just for matters of convenience. That person with an extreme crap gap might not be the ideal candidate for it, though.
An anonymous attendee wants to know if there's ever been a permanency to B cell depletion, zero B cells on blood flow cytometry with Ocrevus or Briumvi, and if so, is there a treatment for that?
So I have seen people take a long time for their B cells to bounce back. So we expect your CD19 as a marker of your B cells to be zero when you're on one of these drugs, or it should be close to it. Typically, those cells are going to start repopulating somewhere in the 6 month range, but humans are humans. We're variable. I have seen people go a year and a half or more before they're totally repopulated. I've never seen it permanent. And my thought, if you're getting out past a year and a half and your B cells are not repopulating, I want a hematologist involved to tell us if there's something else going on.
Thank you. Katie says, regarding Mavenclad, would you recommend it to someone who has a family history of breast cancer? I know it was stated that the cancer risk seems low.
Yeah, I'm fine with Mavenclad and someone with that family history. I would want you to get mammography or and any other testing that is appropriate from your primary care doc or GYN before you start it. But I wouldn't. That's not a deal breaker for me.
An anonymous attendee wants to know if glatiramer acetate can cause bone issues in individuals over 65. What are the disadvantages? Been on it for over 25 years and now have knee osteoarthritis.
Yeah, I have seen zero bone issues with glatiramer acetate. Yeah, I think glatiramer is probably the safest disease modifying therapy we've ever had and probably ever will have. The major thing with glatiramer is just the hassle of doing the shots and the injection site reactions and that occasional post-injection reaction, which can be unpleasant, but it is not dangerous. I mean, really, glatiramer is the only DMT we have that we don't do any blood testing specific to glatiramer. So yeah, it's more just nuisance side effects and hassle factor.
I think it also bears mentioning that in people over the age of 65, osteoporosis or osteoarthritis is fairly common.
Good
But
point.
if you've had steroids to treat relapses in the past, depending upon how many steroids you've had or the dosage, and frequency of those steroids, that can also contribute to osteoarthritis or osteoporosis.
Yeah, great point.
Susan is 67 and has been on 14 milligrams of teriflunomide daily for 14 years. No new lesions or relapses. Moved 5 years ago, and new neurologist said basically, if it ain't broke, don't fix it. My previous doctor said that she would probably recommend stopping DMTs at around 70 if I remain stable. What is your opinion? And again, Susan is 67.
Yeah. Yeah, neither is the wrong answer. Again, it's going to come down to what you would prefer to do. You are certainly in the age range where that discussion of stoppage is reasonable. I would be probably in the let's stop it camp. Just for I like to keep medications to a minimum if we can. There's a tendency for people with MS to sometimes have medicine upon medicine piled up just for their MS, not counting any other health conditions.
Let's see. We've got a couple of people that are repeating comments here. Thank you, thank you, thank you. Love you guys at MS Focus. All right, the person who had been on Rituxan, anonymous attendee, says a follow-up. I had DIV, desquamative inflammatory vaginitis, severe with rituximab. Does that mean all B cell meds are off limits?
If you had, so again, that may be partly driven by how those, and this is speculative, we don't, because that's an unusual reaction, that you could have been at higher risk for that due to the way the B cells are depleted. If it was a severe reaction, and from the way she's describing it, I suspect it was, just the severity of that, might say, listen, we have other options. We don't need to risk that. Let's go to something else. Because again, this idea about how the B cells are killed, we know it's true, but we don't know how much that translates into lower side effect risk. And with that sort of reaction, yeah, maybe we go to something else.
Okay. Pam has another follow-up question. She asked this before, but apparently doesn't feel like it's been adequately answered. Is the lower dose of Aubagio, the 7 milligram dose of Aubagio, effective for 60 plus individuals with CIS without symptoms?
I believe it is. Again, the drug was tested at 14 milligrams, but I do believe we see biologic effect at 7. I have lots of folks on 7, usually due to tolerability issues. They get GI side effects at the higher dose, and I do think 7 milligrams offers some protection.
We're done with the questions in the Q&A at this point, but I've gotten a couple of questions that have been sent to me previously that I wasn't entirely sure how to answer. They've come from people who have transitioned from B-cell therapies to an exit strategy of 2 years of Mavenclad, have not felt like they benefited from the Mavenclad. B cells have populated on the lymphocyte subsets. And one of the things that they're seeing on the lymphocyte subsets is that their CD4 was depressed and their CD8 was elevated, but their white count never changed. So they're wondering if the Mavenclad even did anything.
So did their T cell subsets go down initially with the Mavenclad and then come up?
No, they weren't tested initially with the
Ooh.
Mavenclad. So this is like this is a year after, one of them was a year and one of them was 2 years after the last dose of Mavenclad, the second year last dose of Mavenclad. And they felt like they were progressing. And so their doctor did a lymphocyte subset.
So
And found out that their B cells had populated fully. Their CD19 and 20 were back to normal levels. But the CD4, which had never been altered before, was now low, and the CD8, which had never been altered before, was high.
So we do sometimes see this cumulative effect with things with disease modifying therapies. So like with Mavenclad, we know that after the second dose, some people do maintain this sort of prolonged, even permanent lowering of certain T cell subsets. So that may be what they're seeing. I'm not sure I can explain why the CD8 would be high and the CD4 would be low, but we do sometimes see that very prolonged, even permanent, depression of T cell subsets. We know when you look at chemotherapy patients with cancer management, the more times you hit the immune system with these certain chemotherapies, the longer and longer it takes for their immune system to bounce back. And then sometimes it doesn't bounce back completely ever after certain drugs. And I suspect we see some of that in certain sensitive individuals with drugs like Mavenclad. And then if you kind of throw in the fact that they were on a B cell depleting agent ahead of that, you're kind of whacking the immune system time and again. So yeah.
Was my thought that they had been on the B cell depleters for so long that even a couple of years after, or in one case a year after, in another case 2 years after the Mavenclad,
Yep.
they were still showing a deficit, or an abnormality, not a
Yep.
deficit necessarily. And I kind of thought that maybe it was that cumulative effect of medications that
Yeah.
altered the immune system.
And people need to realize that even though we think about drugs like, Ocrevus as being a B cell depleting agent, most things in the immune system don't dance by themselves. So the B cells and T cells do talk to one another, and you do sometimes see lowering of CD4 and CD8 counts with B cell depleting agents. And there is a certain population of T cells that do express CD20 receptors. So even though we call them B cell depleting agents, they're 99% B cell depleting agents, but they do hit a certain population of T cells as well.
Thank you. This has been very helpful. Thank you again for taking the time to answer those extra
Same.
questions, and for tackling such a topic. I know that it's really only the last 3 or 4 years we've really had these discussions, and really have the information to answer those questions. So I'm grateful to you for taking this time.
Absolutely.
Thank you so much. And on behalf of MS Focus, we very much appreciate your attention to these webinars and your support of them.
Thank you. Thank you for all you do. And thank you to everyone behind the scenes at MS Focus. We appreciate you.